very well chaired first session. You've raised the bar very high, Professor Groman. I'm going to have to do my best here. We've got this session on preparing for battle. We've had the first session, as you know, on the front, the battle front, but we're now preparing for it. And we're going to be basically talking about ways of improving and monitoring vaccination rates. We've got three excellent speakers. The first speaker, Professor Margie Danchin, is a consultant paediatrician at the Royal Children's Hospital and clinician scientist at the University of Melbourne and at the Murdoch Children's Research Institute. She's also a member of ATAGI, chair of the Social Science Advisory Board. She's also a member of the Scientific Advisory Committee at the NCIRS, and she's going to tell us how we can improve childhood immunisation rates. Margie, thank you very much.
Great, thanks very much. Excuse the running injury. All right, well, lovely to be here with you this morning. So this is obviously a very topical thing to be talking about in terms of improving vaccine immunisation rates for kids. So I'm going to firstly talk a little bit about some of the mis and disinformation that we're seeing in Australia and globally, and then touch briefly on vaccine coverage in Australia and our region, hopefully not duplicating too much from what you've heard already this morning. And then I'm really going to focus on, so what do we know? What is the evidence on how to actually improve vaccine uptake and how that links to some of the work that I'm co-leading with NCIRS, the National Vaccination Insights Project. And then I'm going to talk about the role of vaccine communication campaigns and science communication and what I'm most passionate about, which is community engagement and community-led strategies to improve trust in vaccines and uptake. So, misinformation. Well, you wouldn't be surprised to know that misinformation around vaccines is not new. This is that graphic that I'm sure you've all seen before from the cowpox campaign, and you can see the individuals in the background developing heads and appendages of cows, with the assertion that the vaccine caused people to turn into cows. And that was a very prevalent myth at the time. And of course, we're still dealing with that pervasive, disproven myth that vaccines cause developmental behavioural disorders and autism from the debunked 1998 Andrew Wakefield paper that was withdrawn from the Lancet, but still, sadly, more than 25 years later, is still driving this belief that vaccines may cause autism. And in fact, we saw last year that the Health Secretary in the Trump administration put an alert on the website for the US CDC saying that it cannot be, we cannot conclusively say that vaccines do not cause autism. And as you can imagine, this has ricocheted around the world, has restarted the debate, and really started to re-entrench this myth again into people's minds and impact their decision making. And I think what is concerning is that mis and disinformation really has real effects. Now, just to clarify quickly, that misinformation is when incorrect or false information is spread, and disinformation is when incorrect information is spread deliberately for political gain. Or for monetary or financial gain. And I think we've seen a lot of that occurring in the US, where information is spread for political grandstanding and political gain. And tragically, this results in drops in vaccine coverage due to loss of confidence in vaccines and an increase in vaccine-preventable diseases, particularly measles. And as I'm sure you're aware, in the US, there were 2 completely well primary school-aged children that died from measles, completely vaccine-preventable. And, that's an absolute tragedy. And Unfortunately, it is my personal belief that we will see that happening in Australia in the next few years, and it might take something as tragic as that to really galvanise action on a broader scale. So what are we seeing in Australia at the moment? You may have seen these data through the conference over the last few days, but I just want to flag that when we look at the three time points for childhood vaccination in Australia, what we've seen is the greatest decline at the 1 year or 12-month time point. And you can see there in red, in 2025, we've seen a 4.3% decline in childhood coverage at 1 year since 2020 in the dark grey bar. Now, of course, that's a national average, and we have pockets much lower than 90%, and in fact, more than 50% of the PHNs in Australia at the moment in 2026 have coverage for the first dose of the measles vaccine, less than 90%. And timeliness for dose 1 of the MMR vaccine is around 65%. So we've seen a drop in about 13% in timeliness as well. So this represents a real risk to kids. You can see at the 2-year-old and the 5-year time point, it has dropped as well, but not quite as much. Having said that, Australia still enjoys pretty high coverage by global standards, but I think the fact that we're now seeing our worst coverage in more than a decade in Australia is a wake-up call to all of us, and I'm sure Professor Michael Kidd talked about that before. So this is what I was referring to with on-time dose 2 DTP vaccination and MMR vaccination. You can see there in the red at the end of 2025, on time, dose 1, MMR, 12 months, 65%. Very, very concerning. Adolescent HPV vaccination is actually even more of a concern. We've seen about an 8 to 9% drop for boys and girls by 15 years in Australia. And for Indigenous kids, that drop is about 15 to 16%. So what are we seeing on the global stage? Well, you may not know, but the 2 countries in our region that have the most zero-dose children, so those are children who have not received the first dose of DTP or are totally unvaccinated, the 2 countries with the most number of zero-dose kids are Indonesia and the Philippines. But globally, there are more than 20 million children that were estimated to be under or completely non-vaccinated by the end of 2024. So we actually did see an initial recovery after the pandemic, and then sadly, we've seen a decline again in the last 12 to 18 months. So we often use that first dose of DTP as a proxy indicator for how well families are accessing immunisation services. And that first dose of DTP, as I said, in 2019 was estimated to be at around, there were about 12.9 million zero-dose kids, and that has increased now to 14.3 million kids in 2024. The third dose of DTP, which sits at around 85% globally, is more of a proxy for the overall system strength to deliver infant vaccination. And in terms of dose 1 measles, it was estimated at the end of 2024 that about 20 million kids missed out. So what can we do to turn this situation around? And I think this is where it's really important that we turn to the evidence. So the first thing to say is that we're all familiar with looking at disease burden data, vaccine preventable disease data, coverage data by critical demographics, age groups and so on. But we need social and behavioural insights data to actually answer the question of why is coverage low. It's not enough to know where the gaps are, we need to understand why. And I know you hear this a lot, but it's just critical for us to actually understand it and act on it. That helps us to develop and tailor strategies that tackle both access and acceptance to improve uptake and really provide that data for decision making that informs immunisation policy and practice for governments. And of course, we need effective strategies to tackle misinformation, to increase trust in vaccines. And it's my personal view, and backed by the evidence, that it's actually community-led strategies that do that best, not online approaches. So you're all familiar with this framework. I won't dwell on it. This is the World Health Organization framework for measuring these social and behavioural drivers that inform uptake. On the far right there, you can see the grey, that's vaccine uptake. And really, all we need to understand is that that motivation in orange, the intention to get vaccinated, that's where hesitancy sits, that decisional state of whether I get vaccinated or not, or whether I vaccinate my child. That is impacted by what we think and feel about vaccines. That's where vaccine safety concerns come in, understanding about vaccine effectiveness. But it's also influenced by what's happening in our communities, the social norms. What are people saying in our own communities about vaccination? Are healthcare providers recommending vaccination? What is the impact of fathers in decision-making? What about religious leaders and other key social and community leaders? And then, of course, even if we intend to get vaccinated, in the orange, the motivation, it may not happen. And those are where the access or practical issues come in. Can we get to the clinic? Can we afford the vaccines? I mean, we're lucky in Australia, they're free here. Not all vaccines are free. Is the provider respectful or judgmental? And all of those sort of access issues really moderate whether we actually end up being vaccinated. So WHO has kindly linked those three categories to strategies that have evidence to improve uptake. So in the yellow, for the thoughts and feelings, what works to tackle that? That's where we have campaigns to inform or educate the public. And in general, campaigns that work are best for new vaccines. So for example, the recent RSV campaign, for RSV vaccines in pregnancy, or monoclonal antibodies, nirsevimab for infants, something new. We raise awareness, we share something new. Generally, overarching campaigns that tell parents that vaccines are safe and effective, they don't address issues of trust. They don't help the family overcome the recent adverse event their child had. That doesn't work. So it's important to raise awareness. There is a role for those campaigns, but we shouldn't put all our eggs into that basket. Dialogue-based interventions, effective communications, upskilling our immunisation nurses, our GPs, and they do an excellent job. I'm not saying that they don't, but really having evidence-based communication skills and knowledge to share the details about a complex immunisation schedule is what is needed right now. In terms of social processes, this is where we have community engagement. How do we influence social norming in a community? What is the role of vaccine champions and advocates? And I'm going to talk a little bit more about that. I'm not going to touch today on those practical issues, but not surprisingly, the things that overcome access are effective outreach services, weekend clinics, taking vaccines to the community. We saw wonderful examples of this during COVID. For Aboriginal and Torres Strait Islander communities, there were mobile vaccine vans at music festivals with yarning groups next door. Reminders, helping to make appointments bulk billed, improving the number of appointments and drop-in clinics. So these are the things that really help families who are struggling access vaccination. And we can't assume just because the vaccines are free that they can all access vaccines. I'm not going to touch on mandates. It's a very important area. They work, but they do have unintended negative consequences that we need to think about in terms of equity for families. So you've seen this morning. We have an outstanding national immunisation strategy with a 6-point plan, and you can see there the number one is improving access and equity for priority populations. I can't stress that enough. We will constantly see the media framing the gaps in coverage as vaccine hesitancy, and it's just not true. But of course, you can see there building trust, community engagement, improving the quality of our data, harnessing the technologies that we have and improving some of the legislation, the use of mandates, should we have a no-fault injury immunisation compensation scheme? This is an article that I was fortunate to be invited to write with my colleague in the US, Sean O'Leary, which was published 2 weeks ago in the New England Journal. And this summarises a lot of the current evidence globally around what works. So if it's interesting to you, please take a look. So this is the National Vaccination Insights Project that is currently funded by the Commonwealth Government and has just been invested in for the next 2 to 5 years. It's a national survey that's conducted every year of parents under the age of 5 years using a validated survey tool that measures both access and acceptance. And it's the first tool globally that measures both of these buckets of barriers in a high-income country setting that was developed actually by our team at MCRI. So we have some fantastic data. You may have seen this in other presentations over the last few days, so I won't go into great detail. I encourage you to have a look at the Vax Insights webpage on the NCIA's National Centre for Immunisation Research and Surveillance website if you would like to know more. But this is the crux of what I would like you to take home today. This is comparing data from last year in 2025 to 2024. The 2025 data is in the dark blue compared to the light green in 2024. And what is really concerning is the significant increase in concerns about vaccination and loss of confidence in childhood vaccines. So you can see there on the very top the huge increase in parents nationally who say that they do not believe vaccines are safe and they do not trust information about vaccines from their doctor or nurse. So we need to act on that. That'll directly inform strategies that'll make a difference on the ground. The access strategies down there in the bottom in the light blue, they haven't changed that much. And that's really exciting because that tells us that our 2024 data and all of the work that many of you are doing on the ground made a difference. Vaccines are becoming more accessible. But what's going on in the US, the mis and disinformation that's circulating globally is having an impact. And we had almost all parents filling out qualitative boxes in the survey, and I think it was 25 to 30% commented on misinformation from the US, particularly MMR vaccines and autism. So what can we do? This is directly linked to the Vax Insights work. This is wonderful work led by Julie Leask and Kasia and Mareka from NCIA's. And these are the 4 pillars of the strategies that are going to really move the needle. We need to make vaccination services affordable and easy to access and use. We need to support conversations with parents and caregivers about vaccination. That directly links to the loss of trust in vaccines and vaccine information from doctors and nurses. We need to increase community understanding and confidence in vaccination. And we need to improve stakeholders' access to real-time immunisation data to inform strategies in their PHN, in their area, in their region. So this is some of the work that we saw through COVID that really moved the needle here in Victoria. We saw incredible innovation with this sort of work, as I said, with amazing pop-up clinics and taking vaccination to different cultural groups in the community and really promoting vaccination as a way to get back to living our best lives and being able to do the things that we want to do, rather than constantly harping on about safety and effectiveness, which of course is important, but it's not really what necessarily motivates people to go and get a vaccine. This is some of the science communication that's been done around vaccines in the last 5 years. There's amazing work that's come out of NCIA's, the Australian Academy of Science, town halls discussing vaccines openly. The bottom was a town hall in COVID, run in the Melbourne Convention Centre here by Professor Sharon Lewin from the Doherty Institute, where we were peppered with questions for 2 hours from people in the room and over 2,000 people online. That's how we answer people's questions. We're transparent, we're open, we say what we do and don't know, and we're really transparent around vaccine safety. I'm sure you're familiar with some of the sharing knowledge about immunisation, communication resources. These are for providers and for individuals and parents. There are lots of tools. There are resources that are informed by evidence-based communication, and it really covers the lifespan. So Sky now has pregnancy in the newborn, childhood, we're developing adolescent vaccination, adult vaccination, and there's a section for Aboriginal and Torres Strait Islander communities, and then there's a whole section that provides training resources for healthcare professionals. Now, what I'm most passionate about, and that's really how do we engage communities to build trust? And this was never more evident than during the COVID vaccine rollout, where there was just so much misinformation and fear about these vaccines that were perceived to be developed too quickly and not tested enough for safety. No national vaccine campaign is going to cut through the lack of trust or the questions that people have about a new vaccine like that. You know, we know that low levels of trust are associated with vaccine hesitancy, and that if we empower trusted community leaders alongside healthcare workers, we double our workforce and we can really mobilise social networks and friend groups to build confidence in vaccines on the ground. And a lot of this work has been translated for Aboriginal and Torres Strait Islander communities across Australia, for different cultural groups, and we've now taken this work with many others to more than 5 countries in the Asia-Pacific region. And this is the graphic that really represents what I mean by community engagement, that ripple effect through the community of promoting trust, speaking to people directly from people that they already trust, to really build that confidence and ricochet it through the community. So as I said, this started in Victoria, funded by the Victorian government, and has now gone through to some of the regional work in Fiji, Tonga, Vietnam, the Philippines, Indonesia and Papua New Guinea. A lot of it's led by measuring and understanding those social and behavioural drivers of uptake that I talked about, the why coverage is low, to really inform what we talk about in the program, the concerns we address. We managed to really address some of the conspiracy theories in these communities. I'm sure we all saw in Fiji a lot of people walking around with spoons stuck to their arms, with, you know, the concept that the COVID vaccines made people magnetic. Did you see that? Or stuck on their head with a spoon. Those videos were shared, you know, millions of times. So you're not going to counteract that sort of misinformation with a campaign. It has to be from someone they trust on the ground explaining why that's not true. So incredible work going on in the region through the Australian Regional Immunisation Alliance by many of the academic institutions, partnering with Ministries of Health, UNICEF, WHO, key stakeholders on the ground. This is a truly wonderful collaborative effort that is showing real impacts. DFAT has invested more than $15 million in this work. We are seeing increased intention to vaccinate. We're seeing improved communication skills and knowledge in vaccines by both providers and members of the community. So that's some of the work that's summarised from our team, if you want to look up whether I'm telling the truth about impact. So, in conclusion, the pandemic and geopolitics have really reduced trust in vaccines globally. Nearly 1 in 10 people in Australia do not trust information from their healthcare provider at the moment. Access barriers are actually pretty stable, but acceptance barriers are now more strongly associated with both partial and non-vaccination. So it's absolutely critical and urgent to turn this around if we do not want to see a child die from measles or another baby die from whooping cough in Australia. We need to track the social and behavioural drivers. We need to build capacity with providers, not because they lack capacity, but because this is hard. I've been doing it for 25 years and I'm still learning. We need good communication to build trust and confidence, and we really need to reduce the evidence to implementation gap and use data and provide data to governments to move the needle. So I will stop there. It's not going to the last slide, but thank you very much for your time.
We'll just get time for a couple of questions. We've got one question online. Thank you, Margie. What about the 10-minute GP consultation? Is that enough to have a sensible conversation about these issues?
Yes, it is, because it doesn't have to be the only conversation. And I completely respect how under the pump GPs are. And that's why when we talk about effective vaccine communication, we can help you to understand what the key concern is and address it, and at least address that one top concern for that person in front of you effectively. And that might be enough. If they trust you, they may change their mind on the spot. Because actually it's not only about providing more information, it's the trust in the person in front of them and the communication and the fact that you have a non-judgmental approach. And I do believe that can be done in 10 minutes, but it's hard, so we need to practice and learn from each other.
And one question from the floor, Ian.
Keep going, Margie, you do a great job. That survey you had up there with partially vaccinated kiddies, parents, that was a very worrying statistic, going from 12.9 to 50.2, I think it was. People don't think the vaccines are safe anymore. Did you drill down on that to see whether there was any particular drivers, one or two things that stood out?
Yes, sadly, it was the strongest was misinformation coming from the US. So even though we may not believe that information, when a powerful political figure like RFK Jr. or President Trump stands up and says they cannot rule out that vaccines don't cause autism, that has a massive impact. And we're seeing it now play out in Australia. It's very, very concerning. We haven't seen levels of, that decline in vaccine confidence in Australia to that degree before. So, yep, we need to turn it around.
Thank you very much.